Welcome back to Pharmacology. In this block, we'll talk a bit about legal processes and related to pharmacotherapy, including a bit about the drug approval process, the relationship between generic versions of drugs and their branded products, and an overview of some of the agencies that are involved in drug approval and drug enforcement, including the Food and Drug Administration, the Drug Enforcement Agency, and some common regulations that clinicians or providers need to be aware of. So I encourage you to spend a little time navigating through the Food and Drug Administration's website. There's a ton of information on here, including drug information about a number of products. There are safety updates about medications that are posted as safety bulletins on here, information about drug recalls, other issues that are common regarding the safety and efficacy of drugs available in the United States. So please avail yourself of this website. When drugs are developed and approved by the FDA, they're typically done through the FDA or Food and Drug Administration Center for Drug Evaluation and Research, or CDER. This process ensures that the drugs that are marketed in the U.S. are safe and effective. The issue that's different from other countries in the United States is the United States the FDA doesn't directly test the drugs. They have the manufacturer come with the data to the FDA, and the FDA evaluates that. So the usual process is that the company submits a new drug application for a product they want to put on the market. The company tests that, submits its evidence in phases. And so there's sort of pre-human study phases or the animal model phases, and that data gets submitted to the FDA, and then at that point, the Food and Drug Administration, if they think this drug has promise and it looks like from the original data that's not yet human data, is promising and it appears to be relatively safe, they will give the company the blessing to go through a set of phases, phase 1, phase 2, phase 3, for the development of that drug. And CDER has a number of physicians, statisticians, chemists, pharmacologists. They review that sponsor's new drug application, and they look for any elements associated with it that could validate that data that's presented by the drug company. The 4 clinical phases to the FDA are phase of human studies, and these are the phase trials once the animal studies are complete, and now you're looking at study of that agent or that therapy in humans. Phase 1 is a very early study that's fairly short, up to several months, only in 20 to 80 patients, and the primary focus of that study is to study the safety of the medication. Phase 2 then looks at efficacy, and both phase 1 and phase 2 are also beginning to look at what type of doses are associated with what kinds of responses. The company has to go through enough phase 2 data, phase 1 data, before they can move to phase 2. So the phase 1 data gets submitted to the FDA. If the FDA says, hey, you passed phase 1, then they move on to phase 2. Phase 2 has up to 300 participants in it. The study may be of up to 2 years duration, and it begins to study the efficacy of that drug. How effective is that drug for treating the condition that the drug company is looking for a labeled indication for? Phase 3 studies are only started after phase 2 have been approved by the FDA, and they are larger studies up to 3,000 or more patients, and they're done for at least a year, sometimes longer than that. Occasionally, a novel new agent for which there's no therapy might get fast-tracked by the FDA, but typically these processes take years and years to get through all these steps. And this phase 3 study studies are the studies that are going to determine by the FDA whether or not it can be marketed, whether or not the drug company can sell it or not. And these are larger trials, usually multi-center trials, of treating the patients in question. It studies the safety, efficacy, and the dosing. The earlier studies did have some dose ranging questions just to know what dose was appropriate to model for these phase 3 studies. If a drug has gone through all the animal testing and phase 1, phase 2, and phase 3, then the FDA may consider marketing the drug, giving the company or giving the company permission to market the drugs, the company that markets the drug, and puts it on the market. And then this new agent is available for prescribers. As a prescriber, you may have a patient who has a condition for which standard therapy hasn't worked, and at your setting or at a related setting, someone is doing phase 3 trials of a new intervention. You may consider having that patient participate in that trial of a not yet approved agent to evaluate whether that new agent or modality has any efficacy for that patient. But that's pretty unusual to see that happen in practice. You'll do it on rare occasions, but it won't be a common scenario, particularly if you're working in primary care. It's usually going to be a specialist who's going to make that kind of referral to an existing phase 3 trial. Phase 4 happens when the drug is already on the market, and either they're looking at further safety or efficacy data or long-term data, or they're looking at some other aspect. For example, they're looking for a new indication for an existing drug. So it might be an antidepressant that got approved in phase 3 trials for treating depression. Now the company can label that for depression, but they can't label it for treating neuropathic pain. So they may do phase 4 studies for this already approved on the market drug for a different indication, for a brand new indication. That's the most common scenario that you'll see for these phase 4 trials. So phase 1, small group of patients, first time the drug is used in humans. It's evaluating safety and looking maybe at dosage range and some early side effects, but its phase 1 trials set up the feasibility of going to phase 2. Phase 2 trials, a larger group of people in the patients who have that condition. So phase 1, it might have been studied in people who don't have that condition. You're just looking at evaluating its safety overall. You're looking at some biochemical or physiologic properties that drug has related to varying dosing. Phase 2 actually looks at treatment of people with that condition. Is it effective for treating that condition, and also looking at any safety data along the way. Phase 3 then looks at a larger group to really fine-tune the effectiveness, to look for side effects in a larger cohort, particularly for more rare types of side effects, and to quantify those, to compare it to commonly used treatments and collect whatever information that will allow the drug or treatment to be used safely. So what type of monitoring parameters are going to be required for patients who are on this drug once it's in practice. And phase 2 is after the FDA has actually approved the drug for some indication. It doesn't have to be usually it's not the indication they're going for in a phase 4 trial, but it's another indication to see whether or not there's additional data about that drug that would be helpful for clinicians to be aware of. Let's now move from the Food and Drug Administration to the Drug Enforcement Agency. The DEA, Drug Enforcement Agency, really is involved in agents for which there is a potential for abuse or controlled substances. The DEA, the Drug Enforcement Agency, has 5 classic federal schedules for drugs, and they fall into these 5 groups. First of all, Schedule 1 are drugs that have a high potential for abuse, and they don't have, in the United States, an accepted medical indication. Included in this list, you'll see, is marijuana. And marijuana, people will use medical marijuana. The states that allow the use of medical or even recreational marijuana run in the face of what the existing federal law is. So the state law allows it, the federal law does not. The federal law usually supersedes the state law. But at least in the case of medical marijuana or recreational marijuana, the DEA has, in a sense, turned a blind eye to enforcement of their requirements around marijuana. Everything else is fair game. Schedule 2 is an agent which has also a high potential for abuse and dependence, but has some medical indication. So the real difference between Schedule 1 and Schedule 2 is Schedule 1, everything in Schedule 1 has no accepted, federally acceptable medical purpose. That includes marijuana. Schedule 2 includes things that also have a high potential for abuse, but do have a medical purpose. So let's differentiate two products that are in Schedule 1 versus two products that are in Schedule 2. Marijuana, from the federal point of view, is a Schedule 1 substance, but the active ingredient capsules, tetrahydrocannabinoid, the active ingredient of marijuana, are used for nausea, vomiting management and appetite stimulation in a cohort of folks, and those are considered Schedule 2. So THC, the active ingredient in marijuana, is a Schedule 2 substance in the United States, while raw marijuana officially is a Schedule 1. Another example is heroin versus morphine. Heroin is not in the United States considered a therapeutically appropriate agent to use because the euphoria associated with it is high. In the United Kingdom, in fact, heroin had been used for years as part of palliative care, pain management, but in the United States it is a Schedule 1 substance. But the related substance, morphine, is a Schedule 2 because it has been accepted for routine use for severe pain, usually acute, but sometimes chronic pain. Morphine is a Schedule 2 in the United States, while heroin is a Schedule 1. Schedule 3 are some potential for abuse, and they may have some potential for both physical dependence or psychological dependence, and they have accepted medical purposes. And these include things like ketamine, anabolic steroids, testosterone, like. Schedule 4 have a lower potential for abuse and dependence. They probably have more likely to have psychological dependence than physical dependence, but they may have physical dependence as well. There is some abuse for that, and the classic agents in Schedule 4 are the benzodiazepines like Valium, Xanax, Ativan, and the like. Schedule 5, probably of all of them, has still some potential for abuse, but the lowest of all of them with medical purposes. There aren't too many here, but all of these drugs, Schedule 1 through 5, require a prescription, and they could include things like codeine and a cough syrup or products that have Lamodal or something that has some opioid-related products for treating diarrhea or cough suppression. For the most part, Schedules 1 through 5 do require prescriptions. Schedule 1 is not, you can't use Schedule 1. As a healthcare provider, you can't use a Schedule 1. Schedule 2, you can use, a prescription is good for one time. Schedules 3 through 5 all require prescriptions. There's just a couple of exceptions to that rule for Schedule 5, and some states allow Schedule 5 substances to be over the counter with a signature by the patient and providing the pharmacist ID, but that is a more exception than the rule. So let's look through these a little more specifically. Schedule 1 by the DEA, high potential for abuse, no accepted medical use. Occasionally they're used in research, but in your practice you will not be using a Schedule 1 drug. Schedule 2 has a high potential for abuse, both physical dependence and psychological dependence. Their accepted medical use, the amphetamines fall into this group, the opioids, cocaine, tetrahydrocannabinoid. In these cases, you can write a prescription. The prescription is good for only 72 hours, and you cannot write any refills on that prescription. The prescription has to get filled within 72 hours. The amount you can write for is up to a 30-day supply. You can't write for more than a 30-day supply of a Schedule 2 substance, with one exception. If you are working in a patient population that is a hospice patient population and working with a facility or a known or documented hospice provider, there are some provisions for writing a 60-day supply of Schedule 2 for pain, but that's more the exception than the rule. The way to remember Schedule 2, high potential for abuse. You can write one prescription only, no refills. The prescription has to get filled in 72 hours, and it can be only written for up to a 30-day supply. Schedule 3 has less potential for abuse than Schedule 2. There aren't too many groups, meds in Schedule 3. The anabolic steroids, there's a couple others as well, ketamine, but there aren't too many in Schedule 3. Schedule 3, though, you can write a prescription for 30-day supply and up to 5 refills. After 6 months, though, that prescription is null and void. It's no longer valid to be filled by any pharmacy. A Schedule 4 has lower potential for abuse than a Schedule 3. The benzodiazepines fall into this group. A prescription, again, can be up to a 30-day supply, and it can be up to 5 refills for a total of 6 months. Similarly, Schedule 5, a lower abuse potential, typically cough and cold preps. Again, a 6-month rule is what's usually done here. Let's now talk a bit about dietary and herbal supplements. The dietary supplements, there's a limited oversight by the FDA for demonstrating safety and efficacy. Currently, the FDA doesn't have a requirement that the company that makes complementary alternatives, medications or herbal products, dietary supplements, that they have to submit that data in the same way that you saw with standard prescription and over-the-counter medications. There's not a requirement for good manufacturing technique. If, however, the FDA comes across a problem or a set of reported problems with a product, then they will begin to look at enforcing having that drug removed from the market, but they don't really have a lot of oversight in whether or not the drug gets on the market in the first place. The other regulatory bodies that are used in practice include, the Food and Drug Administration, Drug Enforcement Agency are the two we just talked about, but also the Public Health Service and the Federal Trade Commission. The Federal Trade Commission specifically is involved in interstate commerce and looks at labeling or advertising that crosses state lines. So what's on a bottle of an over-the-counter preparation, how a drug, prescription or otherwise, is advertised on television, all of those factors can fall under the Federal Trade Commission. There's also other international bodies, Canadian Drug Control, International Drug Control, that work with the Drug Enforcement Agency. When you're writing a prescription for a controlled substance, there are factors that need to be either on your electronic prescription, which is the most common way that things get ordered now, or on a hard copy of the prescription. But whenever you write a prescription, it has to be for a legitimate medical purpose. It should be dated and signed by you, and it should be somehow written in or generated in some way that is tamper-proof. That is indelible ink if it's on a prescription pad, that the prescription pad can't be copied. For example, if you're writing on a prescription pad or the prescription is printed from your computer system onto paper, that paper is such that it can't be Xeroxed, that when it's Xeroxed, you see copy, 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 copy over the face of that prescription. The prescription needs the full name, address, and identifiers for the patient, the drug name, the strength, the dose form, the quantity being prescribed, the directions for use, your name, your DEA number, and the address of the prescriber. Written prescriptions are always required for Schedule II. You can't do a Schedule II telephone. You can't phone in a Schedule II prescription except in a bona fide medical emergency, in which case you have to follow up within 72 hours to the pharmacy a hard copy of that prescription. So they're very strict. Pharmacies are very strict about that. In addition, Schedule II substances can't be refilled, whereas Schedule III or IV drugs can be issued by phone or in writing and may be refilled up to 5 times within a 6-month period from the time it's issued. If you're looking at either prescription paper or prescription pads, consider them like your personal checkbook. One setting I worked at, for example, there was a separate Schedule II pad compared to a Schedule 3 through 5 pad. And only if you're having prescription pads or paper, keep them in minimal stocks. Make sure they're numbered and locked in a safe area. If you have a theft of your prescription paper or prescription pads, you need to contact the local authorities as well as local pharmacies to let them know your prescription pads were stolen and there may be some counterfeit ones out in the community. If you're looking at writing a prescription, the first issue is you have to have a bona fide patient-provider relationship with that patient. So you're working in an emergency department and a nurse approaches you and says, I've really got a severe migraine headache. I left my medicines at home. Can you write me a prescription for Doesn't matter if it's controlled or not. Well, it kind of does, I guess, but it really doesn't matter if it's controlled or not because you don't have a bona fide patient-provider relationship with that coworker. So if you write a prescription for them, even if it's not for a controlled drug, you take a lot of liability on that's inappropriate. So the general rule is if you don't have a bona fide relationship with that patient as a patient provider, you should not be doing that. Be careful to write legibly. If you're writing in printing, making sure it's in indelible ink, or if your computer system is generating them, that they're done that there's good solid controls in how your system does that. If you are prescribing anything, just make sure you know that it's really needed. You've weighed the risk and the benefit. You know the patient's condition. You know the drugs you're prescribing. So it's really, the onus is yours to be familiar with the drugs you're ordering. That will come with time, and in practice, once you get into your practice area, there are going to be 30 to 50 drugs you are going to use every day. You will know these drugs inside and out because you just use them a lot. But there are probably a couple hundred other drugs that you will order for periodically, but you don't know a lot about them. They don't come off the tip of your tongue. Then look them up. Find the reference you've got on your mobile device or whatever to find the information you need to use those drugs safely and appropriately. If you're looking at starting a med, you want to look for anything else, over-the-counter, prescription, herbal, anything that could interact with it. You want to be clear about the med history you're getting from that patient. You want to be clear about their allergy history. You want to avoid polypharmacy. You want to make sure you're educating the patient well and devising a plan to how you appropriately monitor and treat. And when you're going to discontinue the med, review whether the patient can afford it, is going to get it filled, and that the patient really understands all these variables. When we work later in the year, and at the end of this, we'll talk a little bit about how putting all of these factors together in a therapeutic plan so that you can look at evaluating the safety and efficacy of a particular adding or subtracting a drug from someone's profile and prescribing it or removing it, all the implications and the thought processes that go in that process. You need to also sit down with the patient and make sure they understand how to take their medicines, they know how to read their labels, they don't take their medicines in the dark. I've had the benefit in my earlier career of working at a poison control setting, and you'd be surprised the number of people who would call in the middle of the night who took something because they didn't want to wake up their partner, so they took a med from the bedside stand, they grabbed the bottle and took it in the dark, and lo and behold, they took the wrong thing. Very surprisingly common. Keep medicine in the original bottles, label bottles, so that the patients know what it is, that they know the instructions and who prescribed it, how old it is, that it can be traceable. Now, patients will often use a 7-day pill planner, and for most medicines, if they're doing a week setup at a time, that's okay, but they should also keep the original bottle. One simple thing is when patients are pouring liquids to teach them to pour from the side opposite the label. If you've ever poured paint from a paint can and you poured it over the instructions on the back of the paint can, you became pretty clear that you lost the ability to read those instructions. So if anything drips down the bottle, you want to be aware of that. Encourage patients to get rid of outdated medication beyond their expiration date. And most places around the country, police stations will accept expired meds or no longer current meds, particularly if they're controlled drugs, as a means to get those drugs out of circulation so that people's medicine cabinets aren't filled with opioids, for example, that family members or employees in the house or guests in the house could have access to. And then making sure the patient knows when to call you when something's not quite right. When we think about your liability as a provider, you're going to really be faced with this every day, and the issues are understanding the principle of negligence, where you would have a professional responsibility to act in a way and you didn't meet that standard of practice. So really there are 4 elements we think of when we think of your legal liability. That in a circumstance where something goes wrong, your legal liability falls on 4 things. Let's go backwards here. First with harm, that the patient had some harm. If the patient had harm, particularly if that's quantifiable, then that's a setup to begin to investigate whether or not you're liable for their harm. The other issue is that you had a duty to perform something for that patient. You had a bona fide relationship with that patient as a patient provider to the patient, and your duty was to protect them from harm, to do good and to do no harm, and to practice in a way that was in the scope of practice for your field. And that in the process, you had that duty, and then you breached that duty. You didn't fulfill the duty that was required. The third issue is that there was a causation between your breach and the harm that evolved, and that there was harm. So if in a court of law someone or a prosecutor could address that you had a duty to do something, you breached that duty, that breach of duty caused harm to a patient, then you as a provider are legally liable. So you want to be really aware of that concern in your practice, and practice really in a professional way that's within your scope of practice and not deviating from that scope of practice. The way to do that and to really avoid legal liability is to keep a good open dialogue with the patient and their family. To know the drugs you're prescribing, keep up to date on them, know what your patient takes and run a drug interaction check on them, and advise the patient of any potential problems they might expect with the drug, how to contact you, side effects, and then document that in the medical record. The documentation in the medical record is really important. So you don't want to necessarily deviate from package insert recommendations unless you have a good reason. Early in your practice in particular, if you're doing something that's not a labeled indication for that drug following package insert labeling, then at the very least you ought to be working with your physician who you're working with to establish and review the risk and the benefit of doing something that's off-label or something that's not a standard of practice. You also want to document in the medical record the instructions you gave the patient, and if it's at all a questionable therapy or therapy with some risk for liability, you want to consider getting an informed consent statement for that intervention. So you want to use informed consent and have the patient sign informed consent when you start therapies that are higher risk therapies. And those could include things like estrogen therapy associated with women who have a potential risk for deep vein thrombosis. It could be more complicated informed consent as it relates to starting a course of chemotherapy, for example. For these high-risk drugs, the FDA has a program called the Risk Evaluation and Mitigation Strategy Program. And for a subset of drugs, they will layer on top of the standard labeling a process by which these drugs, which are high-risk drugs, have a particular strategy associated with their management or monitoring. And they require certain things to be done in the case that those drugs are going to be used. You can look at the FDA's website on REMS and get more information on this. But the specific issue you'll see with REMS drugs that require a REMS, are they're often high-risk drugs, and then the FDA requires certain things be done, and they vary based on the drug. One thing might be that in every setting the patient gets the drug, that you have to hand deliver to that patient a medication guide in their language of choice, in easy to read English or easy to read Spanish or whatever the language is, about the package insert. That's a standard guide that's available. Those could often be downloaded from the internet, but you need to make sure the patient gets that and reads that, or if they're not capable of reading it, that someone goes through it with them. You want to make sure that you have a communication plan to other healthcare providers, and or the drug company may have to have a communication plan with you. They may have to determine that before you can use this drug, you have to go through a specific 4 or 8 hour training session to be authorized to use this drug, and then get recertified in that training every couple of years. Or they may only be able to have that drug dispensed by a certain authorized pharmacy that can fill it, that other pharmacies can't fill it, but the pharmacy that does fill it spends time with the patient to evaluate their risk benefits independently of you as a prescriber, and provides that patient adequate information about its safe use. That they're only, maybe the drug is only started or given in a hospital compared to in the clinic, or that there's certain lab testing that has to be done, or there's certain monitoring that has to be done, or the drug patients enrolled on that drug have to be enrolled in a national registry, and that every time that they change care with the provider has to go and determine they've never had a problem with that drug before they start it again for that patient. Example of that last one is Clozaril or clozapine. Okay, very good.